Hi everyone, my name is Trisha Pandey and I'm a PGY2 at Loma Linda University Medical Center in Loma Linda, California. It's a pleasure to be speaking to you all and having the opportunity to present my research today. Our poster is titled An Emerging Arena of Investigation in the Long COVID-19 Syndrome, Cardiac Arrhythmias. SARS-CoV-2, or the virus known to cause the clinical syndrome known as COVID-19, has infected over 200 million individuals worldwide and was officially classified as a pandemic by the World Health Organization in March of 2020. Since the first reported cases in Wuhan, China in December 2019, there have been a wide variety of clinical symptoms and disease processes that have been observed in the infected population. While acute respiratory failure has been the most common presentation reported, there have been a wide array of sequelae noted, such as hypercoagulability, cerebrovascular events, and cytokine storm. There also have been a wide number of studies and case reports detailing the array of cardiac complications seen in acute SARS-CoV-2 infections, ranging from ACS and myocarditis to new onset heart failure and arrhythmias. The incidence of cardiac involvement in COVID-19 is quite significant, ranging from 20 to 30%. Furthermore, there is an established association with cardiovascular injury and mortality, with one study noting significantly higher mortality, about 59%, in patients with cardiac injury in comparison to individuals with no cardiac insult, ranging almost about 9%. I want to draw your attention to this figure I have included here that was adapted from the paper COVID and Cardiovascular Disease by M. Chalazi et al. It's a really good infographic that details the various routes and avenues in which cardiac injury can occur with this virus. Some of the more delineated methods here are hypoxemia, repeated hypotension, tachycardia arrhythmias, obviously the multi-organ failure and critical illness that we unfortunately see in these COVID patients, as well as PE. As we have had time to study this disease process through infection and post-recovery, emerging data from around the world has introduced a new area of interest, the long COVID-19 syndrome. This condition encompasses a myriad of nonspecific symptoms that patients continue to experience despite their initial recovery from disease. Although the chronological criteria for this syndrome has yet to be universally established, there have been various proposed models that have suggested a persistence of symptoms beyond 4 weeks of initial infection that cannot be attributed to any other condition. These studies have reported symptoms such as palpitations, head fog, chest pain, and resting dyspnea. More specifically, there has been an established constellation of cardiac symptoms that are related to the disruption of the autonomic nervous system. Although the exact mechanism is unknown, the ACE2 receptor, which plays a pivotal role in the pathogenicity of the SARS-CoV-2 virus, is also found on neurons. This disruption in the neuronal pathways have been hypothesized to cause various forms of dysautonomia, postural orthostatic tachycardia syndrome, also known as POTS, diaphoresis, and decreased exercise tolerance. The severe cytokine storm and inflammatory process known to be caused by this virus is also another possible cause of the autonomic dysfunction. However, as much as we know, there is still much to be elucidated within this arena, and that warrants further investigation into the pathogenesis, prevalence, and subsequent avenues of treatment that can be employed. And more importantly, there is no significant data on how to surveil and manage long COVID cardiac symptoms, which will be of utmost importance to determine. So our clinical question that we liked to propose was about the prevalence of nonspecific cardiac symptoms reported in patients with suspected long COVID-19 infection. We designed a retrospective study to investigate the burden of arrhythmia in patients who recovered from COVID-19. The cohort for this study consisted of patients who were seen in Loma Linda University Medical Center's COVID-19 heart clinic for symptomatic post-COVID-19 infection. The various cardiac symptoms that were reported included palpitations, exertional chest pain, and presyncope. A total of 67 patients were identified, and these patients subsequently underwent Holter monitoring between March of 2020 to December 2020. The Holter monitoring timeframe was of various lengths, 48 hours or 14 days, and these results were compared to any previous Holter monitor findings. Holter results were divided into 3 categories. No change, so that meant either an unremarkable Holter or no change from previous Holter, sinus tachycardia, or significant atrial tachycardia. Inappropriate sinus tachycardia was defined as the average daily heart rate of greater than 85 beats per minute with symptoms in the absence of significant atrial or ventricular arrhythmias. Now I'd like to draw your attention to our results section. In Table 1, you can see the demographics of our study cohort. As I mentioned before, we had 67 patients. The average age was 52 years. We had 42 females and 25 males. About 12% of our patient population had diabetes, 31% had a history of hypertension, and 7% had a history of coronary artery disease. Figure 1 shows the indication for Holter monitoring in patients with these symptomatic COVID-19 infections. As you can see, the most common subjective complaint was palpitations, as well as presyncope, chest pain, persistent tachycardia, some dyspnea. There were also other indications for this Holter monitoring, such as bradycardia and history of arrhythmias. Figure 2 further elucidates the findings of Holter monitors. The main finding was that there was no significant change in baseline rhythm. However, the most common arrhythmia found was inappropriate sinus tachycardia. And we also delineated those populations between sinus tachycardia and atrial tachycardia. So as you can see in our sinus tachycardia group, the average age was 48 years, 11% had diabetes, 44% had hypertension, and none of the patients in that group had coronary artery disease. In comparison, the group that was found to have significant atrial tachycardia, the average age was 68 years, a fourth of the population had diabetes, 81% had hypertension, and 25% had coronary artery disease. Our study revealed an increase in the burden of atrial arrhythmias in patients with nonspecific cardiac symptoms post-acute COVID-19 infection. Out of a total of 67 patients in our cohort, the most common abnormal Holter monitor finding was inappropriate sinus tachycardia, followed by increased atrial arrhythmia. It's interesting to note that the patients that were found to have sinus arrhythmia were notably younger than those that had increased atrial arrhythmia. In conclusion, the COVID-19 pandemic has manifested in a wide range of clinical presentations. Cardiac injury associated with COVID-19 is of particular interest, especially arrhythmias associated with this infection. While the significance of cardiac involvement in acute COVID-19 infection has been elucidated by many studies to date, there was no study focusing on arrhythmia burden post-COVID-19 infection recovery, and that's where we hoped to show our results. Our study revealed persistent sinus tachycardia as the most common Holter finding in symptomatic patients post-acute COVID-19. The second most common finding was increased atrial arrhythmia burden. Based on the proposed clinical definitions from other studies, many of them are now assumed to be suffering from the long COVID syndrome. To the best of our knowledge, there is no other study so far assessing the arrhythmia burden post-acute COVID-19 recovery and in long COVID syndrome. The above finding is compatible with the proposed mechanism of increased autonomic nervous system activity in long COVID-19 syndrome. Most importantly, further research is needed to investigate the course of long COVID syndrome and the chronicity of Holter findings in these group of patients. Limitations with respect to our study include lack of time-adjusted follow-up after recovery from acute COVID infection, further delineation of significant cardiac history, and sample size. I have included our list of references here, and we would like to thank the patients and the entire cardiology staff of Loma Linda University Medical Center. I really appreciate you all taking the time to listen to my research today, and I hope you all stay safe and healthy.